but I'll begin with how we'll end up in a pathological fracture or a gap non-union in a chronic osteomyelitis. Let me give you a live example and explain to you what happens in the body. Whenever a child presents to a pediatrician or an orthopedic surgeon with a thigh swelling, what happens is the X-ray is generally normal. That is usually in first 2 weeks. And if you can see that here, if you can see that there's always an intraosseous abscess in the metaphysis, proximal or distal, and there is no other pus at any time. So only MRI can pick up the diagnosis at this point of time. Gradually, when the infection is not controlled, there's a subperiosteal abscess, but at this point of time, the vascularity is normal. When you don't treat it properly at this point of time, if you don't drain it, the abscess becomes large. And if the periosteum is strong, what happens is the blood vessels are lifted and that blood vessels are cut off from the one side. If this happens, what happens radiologically at this point of time is there's a rarefication of the bone and periosteal new bone formation at the superior end. But the bone is getting weaker and develops a fracture, as you can see in the lower part here and here. Once that happens, the progress becomes really fast. At this point of time, if the abscess is drained or drains outside, then the things become hunky-dory. This is another view of the subperiosteal new bone formation. But if the infection continues, the bone becomes weak and there will be a fracture on the other end. Now the central part of the bone will lose the vascularity and it will become sequestrum. At this point of time, if the periosteum is intact, what will happen is there will be gradual absorption of the sequestrum, but the intact periosteum will form involucrum and gradually that sequestrum will be absorbed and you will end up in a situation where there will be small sequestrum, but there will be good periosteum which is trying to throw bones. And in these cases, when you remove the sequestrum in a pudor fibula, you get a really good union, as Sandeep has mentioned. But everybody is not so lucky. What sometimes happens is when you have a large subperiosteal abscess and if you don't drain it, what happens is the periosteum and the vascular supply gets cut off. The periosteum then dies and then there is no new bone formation and the bone gradually becomes thin, atrophied, and then it gets absorbed. The clinical example of this is like this child who had fractured at the upper and distal end of tibia, was stabilized like this with infections with multiple KYs, but ultimately ended up in a gap non-union like this. This is the example in which there was no live periosteum to throw new bone formation. In these cases, treatment will be difficult to regenerate the new bone. So now let's look at how can we prevent the pathological fracture. Few examples have already been given by Sandeep. This was a child who presented to pediatrician with pain and swelling for 4 days. An X-ray and sonography was done, which was both normal because it was a stage of intraosseous abscess. The inflammatory paramarkers were significantly high. The child was put on IV antibiotic. 10 days later was referred to an orthopedic surgeon who advised surgery, but parents thought that it's not important to undergo surgery with this large subperiosteal abscess and landed up at my clinic 3 weeks post-op. Now, if you look at here, the X-ray changes are exactly same as 10 days osteomyelitic changes which were apparent on MRI examination. So at this point of time, there was a distal femoral issues. The periosteum was intact and throwing good bone. At this point of time, drainage was done. And then what happened? Did it fracture or not? No, it did not fracture because as Sandeep said, that bone should be protected. I was afraid of putting any metal, but I supplemented this child with hip spica. And this is a 3-year follow-up of the child with excellent function, normal limb length with mild femoral valgus from the regeneration of the bone. Everybody is not so lucky. And there is a situation in which there is a pathological fracture, but the sepsis you have been able to control successfully. Let's look at this serial progression of 6-year-old female who presented to again an orthopedic surgeon with normal X-rays. MRI was not done, and with serial progression, she ended up like this. When she presented to us, she was on a high oral antibiotic for 1 month and a reasonably good function. You know, I could not imagine that this girl has come to me with this type of MRI. There was a significant subperiosteal abscess, intramuscular abscess, and intraosseous abscess as well. This child was debrided, a sequestrectomy was done, and post-operatively, this child was found to have a weak bone. We wanted to do knee spanning fixators, for which parents refused. So she was put on a back slam. And as we know that children cannot be controlled once they become pain-free, she started walking and she presented to us with a fracture. At this point of time, her inflammatory markers were normal, healing, wounds were very nicely healed. So she was just immobilized in plaster because I was very sure that the infection is controlled. This is a serial first 1, 2, and 3 months follow-up. And this is a 1-year follow-up of this child with no limbal discrepancy. But she had some mild deformity and I advised them to remain under follow-up. And 2 years down the line, she came with a fracture. This time there was no pathological fracture. And at this point of time, I thought that it may be good to stabilize with intramedullary rod. But unfortunately, parents did not want any surgery and she was immobilized in plaster again. Now let's look at an example in which active sepsis is there, pathological fracture develops, and surgeon tries to subdue the biological things and try to override the things with his wheel of fixation. This 8-year female in 2015 presented with a sudden pain and swelling in left thigh. She had a high-grade fever. She went to an orthopod. Investigations were done. X-ray was done. No MRI was done. She was put on. She was admitted. IV antibiotics were given. She improved gradually. Antibiotics were withdrawn, and only oral antibiotic was continued for 1 month and then stopped. Patient was symptomless and mobile. This is the serial progression after 2 months. And after 5 months from the first injury, she presented to an orthopedic surgeon with the same orthopedic surgeon with this X-ray and a fracture. She had an innovative fixation like this, 2 10 nails or probably K-wires with an external fixator. Probably attended one of the IFIX or POSI, but never realized that these are for the normal fractures and not for the pathological fractures. She continued to pour significant pus. This is how it progressed. There was a central fragment was getting reabsorbed. So surgeons intervened, removed the implant and put cement. But the dead bone was not removed at this point of time. She presented to me with external fixator, pain, inability to move, and frank mobility once the fixator was removed. She was treated with removal of sequestrum. I removed the old cement chain, and then a cement spacer was created. You can create cement spacer with a 20cc syringe. You can put it on one side of the bone, put an intramedullary K-wire, and then put cement and put the second half alongside on the other side. So you get a reasonably secure round cement spacer. This is how the cement spacer looks at the end, and this is how it looks radiologically. Here, some length was compromised. Everything healed. We waited for 3 months and then intervened with fibula grafting, iliac bone grafting, and as Tarul suggested, intramedullary nail is not only enough. I added a locking plate also. But to my misfortune, at 2 months follow-up, she started developing sinus, and all the grafts started getting absorbed. So at this point of time, with bone graft absorption, there was no other option for me but to remove the implant, do an acute compression, and remove all the dead bones. This is a 3 and 6 months follow-up of the same child, and this is a 1-year follow-up. You can see there is a significant limb length discrepancy. There is restriction of knee movements, but she is able to walk very well. And this is how the bone has reincorporated. I have advised them for lengthening, but they have not come for lengthening. And this was done about 4 years back. Now, let me give you an example which probably Sandeep has already given. And this child with chronic osteomyelitis with the pericardial abscess, we did sequestrectomy and she was reconstructed with fibula. And as Sandeep said that fibula, it works very well, but in my experience, sometimes fibula needs an additional procedure. She united very well proximally, but distally she did not unite, and then I had to do a bone grafting, after which she successfully united. And this is a 5-year follow-up of the same patient with good physical function and regenerated ulna. Let me take you to a little longer example of Huntington, the same girl which we saw earlier. She had a Huntington's procedure done. I could get the union on the first side. You can see it is very well balanced. There is no deformity. At 1 year follow-up, she had developed non-union at the proximal end, for which she had bone grafting and screw fixation, following which she healed well. But if you look at it, there is a deformity here. The reason of the deformity was growth arrest, which was already there in distal ulna because there was a fracture. And proximal ulnar physis was also not normal, so she ended up in lengthening. She has shortening. So there was a significant shortening, but there was a reasonably good alignment. She underwent 2 lengthenings at different stages and then opposite tibial epiphysiodesis. And this is her 12-year follow-up. You can see the alignment is reasonably good. She is about 4 centimeters short, and this is how she walks. She has, I would definitely agree with Sandeep that there is an ankle malalignment, but this ankle malalignment is probably due to sequelae of the whole bone getting infected, because in other Huntingtons I have done, there is a perfectly normal alignment. I chose this case to show you that it's not only the gap non-union which only is the only treatment. There's a multiple sequelae, multiple treatments which are required. So when you are dealing with a sepsis and a pathological fracture, the first thing we must remember, as said by multiple other authors and my speakers, that diagnose them early and intervene in time. Protect the weak bone. Don't rely on patients and parents, and use either full plaster or an external fixator. Active sepsis and pathological fracture, as Sandeep mentioned, and I would concur, control the sepsis first. But from my experience, I will tell you that once you do that, you may do the fixation after 3 months, but still there is a chance of reactivation of sepsis, and be careful with that. Free fibula, I find, is good for upper limb, but in lower limb, you may need an additional procedure. Like additional bone graft, plate fixation, or external fixation stabilization. And you should always discuss and prepare the family for multiple surgeries and few failures on the way, so that they remain with you for a long period of time. Thank you very much for this opportunity.